We discussed a polypharmacy case where someone had a very high anticholinergic burden. They were on high doses of opioids to control neuropathic pain, which isn't particularly appropriate. Also naproxen, which is a non-steroidal anti-inflammatory drug that isn't particularly useful in neuropathic pain, and because of that, they were also on amitriptyline and lansoprazole, which also has an anticholinergic burden. So they had a total anticholinergic burden score of 5. So we had suggested that we would switch the amitriptyline to duloxetine, reducing anticholinergic burden score in that respect. And we were going to start them on a statin because they were 76 years old, using the reprieve data. We were going to switch the lansoprazole to esomeprazole to also reduce the anticholinergic burden score. But yeah, the main thing was the pain review as well. So we talked through the principle of deprescribing, which Katia has explained very well, and also how it works very differently in all of the healthcare systems that we work in. So, for example, in the UK, and Katia described the model that we use in our clinic, we review all of the medication and then we send the recommendations to the general practitioner to action. And that often involves liaison with lots of different specialists as well and lots of fact-finding. However, some clinics have the ability to make those changes and ensure continuation of those changes themselves. So again, really highlighting the difference in different healthcare systems and also the different resources that we all have. And I think that was everything from our case.
So during our roundtable discussion, we explored the experiences, I have to push here, of older adults living with HIV, using Bruno's story as an example. So Bruno is a 58 white gay man living in a nursing home, and he's dealing with encephalopathy with amnesia. So his situation helped us reflect together on some broader themes that affect many people in similar circumstances. So I heard words like stigma, disclosure, he has to go back in the closet, and then as a cultural competence, being LGBTQ, rejected. I had an example even of someone, a person living with HIV in a nursing home, was being locked in his room. Also, what about soft or low-level stigmatizing, and that there is no consequence for people who stigmatize. So his situation helped us reflect together on some broader themes, as I said. So first we have complex needs. Aging with HIV often comes with multiple health conditions. People may face mobility issues, memory changes, or other complications that make daily life more challenging. Then there is the adherence challenges. Taking medication every single day for years isn't easy. There is treatment fatigue, there are side effects, polypharmacy, we just heard it. Emotional and social struggles can all make it difficult to stay consistent. And then third, there's also a social and environmental factor. It's not just about the individual. There is stigma, there is loneliness, there are limited autonomy in care settings. Also, care settings are not everywhere the same. In every country, the care is different organized. Everything of that can all weigh heavily on people, both on the treatment adherence, but also on the overall quality of life. So social support, respectful care, and tailored interventions make a real difference. To live well with HIV in later life, we need to focus on physical and mental health, on strong social support, and a care environment that respects each individual. So thank you all for your insight and for sharing your perspectives during these discussions.
My talk or my presentation should be, can prevention and stigma reduction increase the quality of life of HIV adult aging people? We have discussed, we have said yes. The problem is that prevention should be theoretical, in the meaning that when we see our patient, we don't have always the time to do what is really prevention. Very often we answer the question that the patient will ask us or the problem that he reports. And this should be connected to a lack of time, lack of resources, and not always we have the possibility of really considering the patient in the full, in the holistic way. Sorry, and about the stigma reduction, it emerged that the stigma is still present. We are living in a situation that is still or is very similar to the 80s when we discovered that HIV was a problem. Now is a problem that is begun thanks to the therapy, antiretroviral. It's a chronic condition and allows the people to live longer as normal people, even if the quality of life of these positive people is lower than the normal people. The reduction of the strategy and for the reduction of the stigma are surely positive because they increase the self-esteem, will allow the people to meet, to go out from the isolation, to be part of the society, be part of the life of the world that is living, and what's outside the house in practice. We, as healthcare workers, have to improve the reduction of stigma. The problem is that since during the recent year, especially I say the situation in my hospital, the outpatient clinic, that were followed. In case of need, the doctor will made a prescription and he made an appointment directly. Now you have to arrange by yourself to go to the specialist, and this is lived like a problem because not all the healthcare workers are ready to treat, ready to have a contact with the patient with HIV, owing the stigma. Another problem or another strategy should be the one of adapting as well, or more that we can do, the patient-related outcomes to the situation of this patient, because PROs usually were made or tailored by aging people or older people, sorry, and not especially for HIV or not always for HIV. So mixing or try to melt the two situations, it's probable that we have the probability or the opportunity to reduce the stigma and improve the quality of life of these people. The biggest problem, I repeat, is lack of time, lack of resources. I could say ignorance or not information about all the healthcare workers that are or should be in contact or will be in contact with the HIV patient. Thank you.
Thank you. Hi, everybody. We are happy with Eleonore, who stayed there because she prefers French speaking. We were a friend group. We talked about a patient, age of 65 years, that we saw together, and he had. Maybe you can put the slide.
C'est moi?
That's me. Oh, sorry.
Yeah.
So the old patient, he said he was heterosexual, and actually he had a break in his treatment during many years, and then he consulted frequently for infections, especially around the anal area, and after 8 years he had a novel treatment, well tolerated, but he always had depression, stigmata. He was sad, and he said he kept secret his disease, and very isolated, no friends, no one to tell about, and still infections in sexual area, and maybe we talked about stigmatization, auto-stigmatization maybe, and the difficulty to live with his disease and accept it. And he was very asking for a change of treatment with injectable treatment, and we saw him with Laure doing educational program with a group session where we talk with patients and we ask patients to participate actively, especially with the cards we elaborated with questions, and the person have to say that if it's true or wrong, and we discuss together about that, and it permits to speak about this treatment on all the challenge it permits, it allows, but also constraints, barriers that people have to keep in mind to be adherent a long time after. And this man it was for him a good option, because he said what I'm looking for is to forget the disease, and taking a drug every day remind me I have an infection and I want to take distance from it. So it was interesting to speak about this treatment option for this kind of treatment with difficulty of acceptation, but this one was still adherence. And we had interesting discussion about different the way to keep this to get these drugs at hospital only or in town, and also with Bernard, we said people keeping secrets the treatment had less chance to be adherent. And thank you for that. It was interesting, and yes, we had nice exchange together.
Thank you. Thank you.